This is QD Clinic. Hi, I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live. Collectively, we're a whole lot smarter than we are individually. This is at the root and the drive behind the design of RheumNow Live, where we put you and your peers to test. We want you to be involved with polling questions, cases coming from some of the best teachers that we have in rheumatology, and a lot of time for Q&A. This is how we all get smart together. Our case today is undifferentiated arthritis, and what should I do when the rheumatoid factor is positive? So a 43-year-old man complains of arthralgias in his fingers for the last 3 months. The PCP sends you the patient with some labs already done. The rheumatoid factor was a high positive 250, but a negative CCP. The CBC was normal, the ANA was negative, Hep B, Hep C was negative, the SED rate was 10, the CRP was undetectable, uric acid is normal, B27 is negative. The patient has a history of arthritis, but he's not sure what kind because it was his grandmother and he never really met his grandmother. He himself has no discernible important medical history, has never really been in the hospital for anything. Currently not taking any medicines because it's just these fingers that are bothering him the most. And the question is, what should he do about it? And what are you going to do about it? So when you examine the patient, you really find nothing on an extensive physical exam. When you press on joints, you find some tenderness over bilateral MCP1s, that thumb MCP. Both are tender. Hence, when he has grip problems or grip issues, that's when he's reminded of his discomfort. So the question is, could he have RA with just those two thumbs involved? And when would you possibly consider starting him on a DMARD? He does not meet criteria for rheumatoid arthritis. You could follow him and treat him symptomatically. You could order extensive batteries of tests. I wouldn't order for any further testing on him at all. I would probably follow this gentleman, but the question is, what does it take for you to use a DMARD? There are a growing number of studies right now that are appearing about treating patients with undifferentiated arthritis and what to do about it. We covered it in last week's podcast that you shouldn't do MR on a patient like this unless they are seronegative and have oligoarthritis. Because if they have seropositivity, especially CCP, they have a 20 to 60% chance of progressing to rheumatoid arthritis, and just let the exam teach you what to do. If they're seronegative, it's really very, very low risk of developing. Our patient has rheumatoid factor, but not CCP, so not quite as high a risk as you would with CCP. The other reason to do an MRI is not just seronegativity, but also oligoarthritis. This guy has really a monoarthritis, maybe two thumbs that I consider a monoarthritis. I think if he had 3, maybe 4 joints, then maybe an MR in the hands would show you something that would be useful. But generally, I don't think I would order it. Technically, he does have oligoarthritis with 2 joints, though, right? Other things that we've learned from the literature. The Prairie study, 1 single infusion given to at-risk individuals. That's what we call that preclinical RA, first-degree relative with arthralgias, no synovitis, and maybe an elevated SED rate or CRP. That 1 infusion of rituximab did not prevent RA, but did forestall the onset of RA. So following patients out for 3 months, there was just overall less RA being developed. But over time, they got caught up, meaning it was 40% of people on placebo got RA and only 34% on rituximab with 1 infusion. And in the end, they all got together. If you had kept treating, maybe you would have kept it away. More recently, we talked about the ARIA study, ARIAA. It's an abatacept intervention trial, 6-month trial, placebo versus abatacept. And in 100 patients, they showed a lot less RA developing in the Orencia group compared to the placebo group. 35% of placebo group developed rheumatoid arthritis, only 8% in the abatacept group developed it. So you can show some benefit. The question is, does he have, first off, those studies were done in CCP positive patients with a little bit more as far as symptomatology or findings. For instance, to get into these studies, you had to have an abnormal MR, but no swelling. You have to have inflammation on MR. So when we discuss this with a large number of rheumatologists, most people are going to just treat this symptomatically and not use a DMARD like hydroxychloroquine or methotrexate until you develop one or two or more swollen joints. That seems to be meaning that you just treat what they have, as opposed to, why not give them methotrexate or abatacept, or hydroxychloroquine? It's safe. You can't get into trouble, and I'm going to follow them. The question is, if they never develop a disease, how will you know? It's a little bit like the thermos. That's a joke. Look up the thermos joke. So for me, I would need to see probably 2 swollen joints or imaging evidence of tenosynovitis. There's a lot of good literature, especially from Paul Emery and others, showing that tenosynovitis as a finding has high predictive value for future development of rheumatoid arthritis. And what would I use? I would start with methotrexate. Some people might start with hydroxychloroquine. But right now, we're waiting on some other trials. There's another big one coming out with abatacept called ARIPA, and there's a very big one called STOP-RA using the intervention hydroxychloroquine. Until such time we have stronger evidence, I think we're still going to be just treating these symptoms and not necessarily calling this a disease and jumping in with a DMARD. Tune in for more QD Clinics.